Welcome back to the deep dive. We've got a stack of notes right here, straight from one of you, a listener deep in the throes of MSRA revision.
Ah, revision time.
Exactly. So we're taking these detailed notes and launching a deep dive into a cornerstone topic, menorrhagia, or heavy menstrual bleeding.
That's right. Our goal today is to, go beyond just reading the notes. We're going to unpack them together, highlight the absolute key insights you need to remember.
Make it stick.
Yeah, make sure the core information sticks, ready for quick recall during your revision. Think of this as a high-yield distillation tailored just for you, using your own study material as our map.
Our mission, to journey through everything about this condition, from its definition and causes to how it's investigated and managed. We'll pull out those essential nuggets, flag important details.
Maybe a memory tip or two.
We'll see what we can do. Ready? Let's jump in.
Okay, so let's start at the very beginning. What exactly is heavy menstrual bleeding, or menorrhagia?
Well, the notes lay out the fundamental definition for us. It's excessive or prolonged menstrual bleeding. At its heart, it's characterized by an increased amount of blood lost during menstruation.
And traditionally, that excessive part had an objective measure, didn't it? Sort of a number attached?
It did, yeah. Historically, it was often defined as a total blood loss greater than 80 milliliter per cycle. But crucially, and this is a really important point the notes emphasize, there's been a significant shift. The focus is now much more on the subjective assessment, specifically the impact it has on a woman's quality of life.
And that shift makes so much sense, doesn't it? Because how it affects your ability to live your life, well, that matters more than hitting some arbitrary number.
Totally.
The notes bring in the NICE definition here, reinforcing this point by defining heavy menstrual loss as excessive blood loss that affects physical, social, emotional, and quality of life.
Exactly. They also explicitly link it to increased limitations in daily activities. So the practical definition really hinges on a woman's perceived ability to manage her bleeding. For context, normal cycles typically average 21 to 35 days. Bleeding lasts around 7 days, and the flow is usually heaviest at the start.
And the average loss is way lower, right? Like 30, 40 milliliters.
Yeah, the notes mentioned average loss is only 30, 40 milliliters, which really highlights just how far excessive bleeding can go beyond the norm.
The notes also quickly touch upon some related terms that are helpful to differentiate. You might see menorrhagia mentioned, that's bleeding at irregular intervals, so not during a period.
Then there's menorrhagia, which is sort of both bleeding is frequent and excessive.
Polymenorrhea describes cycles that are unusually short, less than 21 days apart.
Dysmenorrhea, that's just painful periods.
Simple enough. And a big one the notes highlight is dysfunctional uterine bleeding, or DUB.
Ah, yes, DUB.
This is abnormal bleeding where you can't find an obvious underlying structural problem or systemic disease. Importantly, DUB very often presents as menorrhagia, accounting for a large chunk of cases. We'll probably come back to this.
Definitely. So that gives us a clear picture of what it is, but what's actually causing it. The notes list a whole diverse range of possibilities under etiology.
They really do. It points to everything from hormonal imbalances and specific uterine conditions to bleeding disorders, broader systemic diseases, and even certain medications. A real mix.
And digging into those notes, what emerges as the single most common cause when there's no clear structural issue? Is it that DUB again?
That's where DUB comes back in exactly. The note stated accounts for a huge proportion, 40–60% of cases. It's that diagnosis you arrive at when the excessive bleeding is there, but investigations don't reveal a specific pathology like a fibroid or polyp.
And often, underlying DUB, especially at certain ages, are anovulatory cycles where an egg isn't released.
Yes, that's a key connection the notes make. Anovulation is particularly common at the extremes of reproductive age, like during adolescence when cycles are just starting.
Right, getting established.
And then again during perimenopause. Those transitional times are kind of hot spots for DUB due to hormonal fluctuations.
Okay, so beyond DUB, specific uterine conditions are high on the list of causes, things inside the uterus itself.
Yes, structural stuff. We're talking about things like uterine fibroids, those benign growths, and endometrial polyps, which are growths from the lining.
Adenomyosis is mentioned too. That's where the tissue that normally lines the uterus starts growing into the muscular wall of the uterus itself. Bit different.
Yeah, and endometritis, an inflammation of the uterine lining, can also cause it.
And critically, the notes draw our attention to endometrial hyperplasia, which is thickening of the lining, or even carcinoma cancer.
That's a really important one, especially in women over 50 presenting with new abnormal bleeding. That's a definite red flag to watch out for.
Good point. Systemic diseases also get a mention. hypothyroidism, liver or kidney disease, obesity.
And crucial bleeding disorders like von Willebrand disease. It's a good reminder that bleeding issues in the uterus aren't always just about the uterus itself.
Right. Look broader.
Exactly. And the list continues. IUCDs, intrauterine contraceptive devices, can sometimes increase menstrual flow, certain medications, pelvic inflammatory disease,
Yeah.
and more general hormonal imbalances beyond just an ovulation, including thyroid issues, can all contribute. It really is a broad differential.
It is. If you're trying to remember the major categories, maybe thinking of something like that. PALMCOEIN mnemonic helps, even if the notes group slightly differently.
Yeah, that's a useful framework. Polyps, adenomyosis, leiomyoma, fibroids, malignancy and hyperplasia, and then coagulopathy, ovulatory dysfunction like dubinovulation, endometrial causes, endometritis, iatrogenic meds, IUCDs, and not yet classified helps structure the thinking.
Definitely helps organize it. So thinking about who's most likely to experience this, are there specific risk factors the notes highlight?
Age comes up again as a primary factor, specifically adolescence and perimenopause, linking back to those hormonal shifts and anovulatory cycles we just discussed.
Right, those extremes of reproductive life seem particularly vulnerable.
Exactly. Other factors listed are a family history of heavy menstrual bleeding, existing medical conditions like polycystic ovary syndrome, PCOS, and endometriosis.
Ah, okay.
And logically, the use of medications known to affect bleeding or clotting, like anticoagulants, makes sense.
Now let's touch on the nuts and bolts of how the bleeding happens, the pathophysiology. What's actually going on?
Well, the notes acknowledge that the precise mechanism varies depending on the specific underlying cause, which, makes sense given the long list we just ran through.
Of course, a fibroid causing bleeding is different mechanically from a hormonal imbalance causing an ovulation.
Right. But the notes do identify some general threads that contribute to excessive bleeding across different causes. These include hormonal imbalances affecting the uterine lining, physical abnormalities in the uterine lining itself, like those polyps we mentioned, and sometimes increased fragility of the blood vessels in the endometrium. Basically, these factors disrupt the normal clotting and shedding process, leading to heavier or prolonged flow.
Okay, so when someone presents with heavy bleeding, what other conditions should be on the radar? What's the differential diagnosis list from the notes? What are you actively trying to rule out or confirm?
The notes provide the key conditions to consider in a clinical scenario. It's essentially a focused list drawn from the causes we talked about.
Okay.
You need to differentiate between dysfunctional uterine bleeding, often that diagnosis of exclusion after ruling out others, endometrial polyps, uterine fibroids, endometriosis, and crucially, gynecological malignancies.
Right, ruling out the serious stuff.
Exactly. Thinking about it in this way helps structure your approach to investigation. You're asking yourself, is it likely DUB, or could it be one of these specific structural or pathological issues?
Turning to how common this is, do the notes give us any numbers on the epidemiology? How widespread is it?
They do, providing some context, particularly for the UK. Approximately 25% of UK women experience menorrhagia at some point.
Wow, 1 in 4 women. That's a significant number. It highlights how common a presentation this is likely to be in practice.
Absolutely. It's most frequently reported in women aged 30-49 years, peaking in that age group.
Okay.
The notes also reinforce that distinction between objective measurement, where prevalence might be 9-14%, and subjective reporting, which goes up to 20-52%.
Ah, that subjective impact again.
Yeah, it underscores that the subjective experience captures many more women affected by this. Menstrual disorders overall, including menorrhagia, account for a notable 12% of gynecological referrals.
Significant workload.
It is. And yes, it's specifically noted as common during menarche and perimenopause, reinforcing the risk factor data we mentioned.
Okay, let's switch to the clinical presentation. When a patient sits across from you describing this, what are the key features the notes tell us to look for and ask about?
Well, the most obvious sign is the excessive menstrual bleeding itself. The notes describe it as requiring frequent changes of pads or tampons.
And that classic sign of needing to use both a tampon and a pad simultaneously.
Yeah, that's a practical indicator often mentioned, showing really heavy flow. And the passage of large blood clots is another key thing, sometimes described as painful as they pass through the cervix.
Right, that's a really common symptom reported.
It's a strong indicator of heavy flow. Prolonged bleeding, lasting more than 7 days, is also a defining characteristic.
And because of the chronic blood loss, symptoms related to anemia are very frequent, things like fatigue, weakness, shortness of breath, feeling generally wiped out.
Precisely. The notes also emphasize the impact on daily life disruption to work, Social activities, exercise, tying back to that subjective definition and quality of life
Makes
focus.
sense.
Interestingly, they mentioned that while heavy flow is often worst in the first few days, there's not necessarily a correlation between the duration of bleeding and the total volume. So longer doesn't always mean more overall.
Huh, okay. So during a consultation, beyond the bleeding itself, what else should you be assessing? What are the key questions?
The notes recommend specifically asking about those anemia symptoms we just mentioned. Crucially, assess the impact on daily life and work how is this actually affecting you.
Really get into the quality of life aspect.
Exactly. Review their full medical history, paying special attention to any personal or family history of clotting disorders or easy bruising or bleeding gums.
Good flags.
And it's essential to discuss their contraception needs and fertility intentions, as this will heavily influence management choices down the line.
Very important point. And the physical examination, what are we looking for there?
You'd look for signs of anemia like pallor, paleness, or koilonychia, those spoon-shaped nails. The exam also helps rule out potential organic causes contributing to the bleeding.
Okay.
Notes suggest assessing general appearance, BMI, and looking for signs of any underlying endocrine issues, like thyroid problems perhaps. Always perform an abdominal exam first.
Before the pelvic.
Yeah, then consider a pelvic exam. It's not always needed initially, but the notes suggest considering it based on the history if you're planning certain treatments or if initial medical management isn't effective.
Right.
It's also vital to ensure their cervical smear is up to date. The exam involves inspecting the cervix, maybe taking swabs if indicated, like for infection, and performing a bimanual examination if you suspect abnormalities like fibroids or issues with the uterus or ovaries.
Right. We've got the presentation and the assessment process. How do we investigate further? The notes list a series of key investigations.
Right, the tests. Blood tests are absolutely fundamental here.
Top of the list has to be a full blood count, right?
FBC.
Exactly. The FBC is essential to check for anemia, which is such a common and important consequence of significant blood loss. Hormone tests, like thyroid function tests, are done if the history suggests a possible endocrine cause.
The notes mention something called a pictorial representation. What's that about? Yes, this is a practical tool, like a menstrual chart or diary, sometimes specifically called a pictorial blood loss assessment chart, or PBAC. It allows women to subjectively quantify how heavy their bleeding is over a cycle. Helps give a clearer picture.
Ah, okay, like tracking pad usage visually.
Kind of, yeah.
Yeah.
Beyond routine tests, specific investigations for endocrine problems or bleeding disorders are done if the clinical suspicion is high after taking the history.
What about imaging? Seeing what's going on inside.
Transvaginal ultrasound, TVUS, is a cornerstone investigation. It's recommended if the history or pelvic exam suggests there might be structural or histological abnormalities within the pelvis or uterus.
What can I pick up?
It's excellent for identifying things like fibroids, polyps, or abnormalities in the uterine cavity or endometrial thickness. The notes give a specific value here. A normal endometrial thickness in premenopausal women is typically less than 12 millimeter. That's a useful number to keep in mind for interpretation.
Good figure. And sometimes you need to look inside directly with a camera.
That's where hysteroscopy comes in. Outpatient hysteroscopy, using a small camera to visualize the inside of the uterus, can be offered if submucosal fibroids, polyps, or other endometrial pathology are suspected.
And if outpatient isn't okay.
The notes mention options for anesthesia if outpatient isn't suitable, so it can be done under different settings.
Okay. When would a biopsy of the uterine lining be indicated, according to the notes? Taking a tissue sample.
An endometrial biopsy is crucial in specific scenarios to rule out endometrial cancer or atypical hyperplasia, particularly when malignancy is a concern.
Right, the red flags again.
Yeah. The notes list clear indications. Persistent bleeding between periods, intermenstrual bleeding, heavy bleeding that hasn't improved with medical management, women aged over 45 years with heavy menstrual bleeding, again, watch out for that older age group, and any other clinical features that raise suspicion.
And there are clear indications for referral to secondary care listed too, right? You want to send them on.
Yes, the notes make these clear decision points. You'd refer urgently if there are symptoms or signs suggestive of malignancy. That's a 2-week wait usually.
Okay.
Referral is also needed for iron deficiency anemia, not responding to standard iron treatment. If the woman prefers surgical management from the outset, if you find any significant abnormality on physical examination, or if there are known risk factors for endometrial cancer or hyperplasia that warrant specialist assessment.
The notes also summarize key NICE recommendations for managing heavy menstrual bleeding, which are helpful for context.
They do. The NICE guidance emphasizes taking a focused history that specifically captures the impact on quality of life back to that subjective definition again.
Always comes back to that.
It does. They recommend offering outpatient hysteroscopy if pathology is suspected, ensuring a comprehensive discussion of all available treatment options so the woman can make an informed choice, and considering endometrial biopsy in those specific cases we just mentioned. This really maps out the recommended investigation pathway.
Okay, we've defined, explored causes, identified risk, covered presentation, and investigated. Now the crucial part, how is menorrhagia managed? The notes provide a clear stepped approach.
They broadly group management into lifestyle modifications, though specific details aren't really provided here in these notes, pharmacological options, medications, and surgical interventions.
Let's start with the medications, as the note suggests this is often the first step, particularly in primary care.
Right. For medical management, if contraception is not required, the notes recommend starting with options like mefenamic acid, which is an NSAID, or tranexamic acid, an antifibrinolytic.
How do they work differently?
Well, NSAIDs reduce prostaglandin effects in the uterus, while tranexamic acid helps stabilize blood clots, reducing breakdown, so different mechanisms.
Okay. If contraception is needed or desired, the notes strongly position the Leviner gestural intrauterine system, LNGIUS, like the Mirena coil, as a first-line medical option.
That's a key recommendation. It's highly effective at reducing menstrual bleeding while also providing long-acting contraception, a real two-in-one.
Makes sense. Combined oral contraceptive pills or long-acting progestogens are also listed as hormonal options if LNGIUS isn't suitable or preferred, and they also provide contraception.
Yes, other options exist. And for a situation where you need to rapidly stop very heavy bleeding in the short term, like an acute episode,
Oh, yeah.
the notes mention using northistrone at a dose of 5 milligrams 3 times a day as an option for acute heavy bleeding control, though it's usually for a limited course, not long-term management typically.
Okay, short-term fix. It's good the notes clarify that medical treatment can often be initiated in primary care and doesn't always require referral. The core aim here is always improving symptoms and that vital quality of life piece.
Yes, absolutely. And the consistent medical options highlighted throughout the notes for chronic management are the LNGIUS, tranexamic acid, NSAIDs, and combined oral contraceptives. Surgical options are typically considered when these medical approaches haven't worked, aren't tolerated, or are contraindicated.
The notes do state that surgical intervention is often more effective than medical treatment overall in terms of reducing the bleeding amount.
They do, but it's obviously a step up in invasiveness and risk. Endometrial ablation, a procedure that destroys the uterine lining, is recommended if the uterus is not significantly enlarged. The notes say less than the size of a 10-week pregnancy.
And there are different ways to do that.
Yes. The notes list various techniques for ablation, such as radiofrequency, balloon thermal, and microwave ablation, different methods to achieve the same goal.
And for larger uteri, or if fibroids are the main issue.
For larger uteri, especially if fibroids are the cause, other options like uterine artery embolization, UAE, or hysteroscopic myomectomy, removing fibroids from inside the uterine cavity via hysteroscopy, may be considered.
Okay. And the ultimate surgical option, hysterectomy, removing the entire uterus. That's a significant procedure.
The notes are very clear and cautious about hysterectomy for heavy menstrual bleeding, particularly DUB. It is explicitly not recommended as the first-line surgical treatment for DUB.
So reserved for specific cases.
Absolutely. It's reserved for when less invasive treatments have failed or contraindicated, or the woman has considered all options and specifically requests it. Other specific indications mentioned are a desire for permanent amenorrhea, no periods ever again.
Right.
When the woman is fully informed about the risks and alternatives, and crucially, when she has no desire to retain her uterus or future fertility.
And they list potential unwanted outcomes associated with hysterectomy, which are important to discuss with patients.
Yes. The potential risks include a significant recovery time, risks of infection, bleeding during the surgery, potential damage to nearby organs like the urinary tract or bowel, possible long-term urinary dysfunction, blood clots, thrombosis.
DTE risk.
Yeah, and triggering menopausal symptoms if the ovaries are removed at the same time. This list really underscores why it's not the first-line approach and requires really careful consideration and shared decision-making.
Definitely. Shifting towards the outlook, what do the notes say about the likely prognosis for someone experiencing menorrhagia? What's the long-term picture?
Generally, the prognosis is quite good with appropriate investigation and management.
That's reassuring to hear.
It is. The notes state the specific outcome depends on the underlying cause that's identified and managed, as well as individual patient factors. The aim of treatment is always significant improvement in symptoms and quality of life.
So addressing the underlying cause is key.
Exactly. Addressing any identifiable underlying conditions is key to achieving a good outcome and preventing future complications.
Finally, what are the potential complications if heavy menstrual bleeding isn't addressed or managed effectively? What can go wrong?
The most direct and significant complication the notes highlight is anemia, specifically iron deficiency anemia, resulting from the chronic and excessive blood loss.
Makes sense, losing all that blood.
Yeah. And the broader impact on daily life and well-being that we've discussed comes back here as a listed complication.
So the quality of life hit itself is a complication.
Absolutely. The notes list decreased quality of life, impact on emotional well-being, psychological distress, and the overall limitations on daily activities as very real complications if the bleeding isn't brought under control.
And potentially fertility.
While not always the case, if the underlying cause is left untreated, like large fibroids impacting the uterus, it could potentially impact fertility and reproductive health in the long term.
Okay.
So pulling back from all these details from the notes, the wide range of causes, that crucial shift to prioritizing subjective impact on quality of life, the very real complications like anemia, and the structured approach to investigation and management, it really shows you that heavy menstrual bleeding, while a common symptom, is anything but simple.
It really does. It highlights the need for that careful history, that structured thinking about the differential diagnoses, and tailoring the management specifically to the individual, their circumstances, and their goals. It's not one size fits all.
Not at all. And it makes you think about how easy it might be sometimes to just treat the symptom, give something for the heavy bleeding itself without truly digging deep enough to find the underlying why. Is it DUB? Is it a fibroid? Is it something else entirely?
That's a really important point. You need the full picture.
Yeah.
Absolutely. Well, that was a comprehensive deep dive into menorrhagia, pulling out the essentials straight from the notes you provided.
We hope walking through these revision notes section by section, connecting the dots and highlighting those key features makes this topic clearer and the information easier to recall as you prepare for your exam.
Yeah, remembering that structure is helpful, isn't it? Define it. Think causes, poem, co, and outs, helps their risk factors, how it happens, what else could it be, how common, how it presents, how to investigate, how to manage the outlook, and what can go wrong.
That structured thinking is definitely key for exams like the MSRA. Hopefully this deep dive gives you a solid foundation. Keep that revision going.
Keep pushing. And for more high-yield content and resources tailored specifically for the MSRA, remember to check out pastthemsra.com.
You can also find fantastic free resources to aid your studies at freemsra.com. Lots of good stuff there, too.
Best of luck with your preparation. Thanks for joining us for this deep dive.